Greetings, everyone. What are we going over today is provider education for prescription drug monitoring programs, otherwise known as PDMPs. Um, Presentation purpose and objectives. The problem of prescription drug misuse is very complex, with many different precipitants leading to prescription drug abuse and misuse. Um, the adverse impact of drug misuse on a person's life, health, and well being can be very severe. The intervention of prescription drug monitoring programs, or PDMPs, have shown much promise in the literature to identify and intervene in patients at risk or engaged in active prescription drug abuse and dependence. As medication providers, we're in a vital position to make a significant effect on the morbidity and mortality resulting from misuse and abuse of these prescribed drugs. So, what is the Prescription Drug Monitoring Program? What is PDMP? So, it's the electronic monitoring of prescribing and dispensing of Schedule 2 through 5 controlled dangerous substances. And it creates a controlled dangerous substance Schedule 2 through 5 database for prescribers to look at. What are 2 through 5s? They include opioids, opiates such as oxycodone, hydrocodone, methadone, morphine, benzodiazepines as Xanax, Klonopin, diazepam, psychostimulants, the Ritalin, the amphetamine salts, Adderalls, Concerta. Those are some of the more common medicines you see out there that are misused in the Schedule 2 through 5s. Prescription drug monitoring. The goals. It's really there to assist medical and pharmacy and public health professionals in identifying and preventing prescription drug abuse. It's a tool. It's also used by law enforcement to investigate legal prescription drug diversion, and it's data. And the data promotes this balanced use of prescription data that preserves the professional practice of healthcare and provides accurate, best information for providers and patients to access optimal pharmaceutical assisted care. Best practices. The objectives of PDMPs, it's to give healthcare providers, prescribers real-time access to controlled substance history to identify people who are doctor shopping, going from one doctor to another, one provider to another, indicating RX abuse or diversion, intervene with prescription abusing patients, and develop treatment referral and develop comprehensive clinical care. So identifying person who's doctor shopping or misusing prescriptions or at risk for prescription abuse and or demonstrating prescription misuse and supplying them with appropriate treatment referral. It's to also increase the provider awareness and ability to deal with substance abuse and recognize substance abuse. It also improves providers' ability to manage controlled substances effectively, increase their confidence in prescribing decisions for a patient, and increase the ability to determine patient compliance with prescribed scheduled controlled dangerous substances. So, some facts about the PDMP. 48 states have it, 35 are operational. A lot of the other states are in various stages of legislation. So soon it's going to be 50 states nationwide and hopefully all kind of connected. The states, they all have different PDMPs, what they look at, what they don't look at. Some have one schedule, some have all the schedules. And they all have different reporting periods. Massachusetts goes back a year. Different states go back 6 months. And they all allow various groups different level of access and different level of data analysis for providers, public health agencies, researchers, law enforcement, so on and so forth. Here in Massachusetts, all Massachusetts prescribers seeking to prescribe a Schedule 2 or 3 narcotic medication or benzodiazepine to a patient for the first time must research by law the patient's prescription history in the state prescription monitoring program database. So if you're going to prescribe um, Schedule 2 or 3 narcotic medication, um, an opiate, a stimulant, or prescribing a benzodiazepine, you have to look them up. And after October 15th, 2016, prescribers will need to query the PDMP prior to issuing every Schedule 2 or 3 narcotic medication. So anytime you're prescribing the Ritalin or that opiate, you would have to look that up. So how does the PDMP work? For each controlled dangerous substance prescription dispensed, the dispenser, meaning the pharmacy, must electronically report to DPH identifying information for patient, prescriber, the dispenser, meaning the pharmacy, and the drug quantity, dose amount, day supply. And that all gets updated into the database. And we're able to look at that and analyze that. Some of the reporting exceptions, places that don't upload and that data is not available, it's dispensing or direct administration in a healthcare facility. Those are people in the hospitals, of course. Dispensers exclusively serving residents of assisted living, comprehensive care, and developmental disabilities facilities. So patients in long-term nursing homes, that type of thing. Opioid maintenance program dispensing, your methadone clinics. Veterinarian dispensing, of course. And dispensing the hospice inpatient if dispenser is granted waiver by DPH. So a hospice home or a hospice patient there, not reported. But some of these prescriptions can indeed show up on a PDMP if they're filled through a local pharmacy and administered to them. But if they're internal providing through a facility, they're not likely to show up on the PDMP, and they're an exception. So who can kind of look up this data besides prescribers? So number one, of course, is prescribers. Number two is dispensers, the pharmacies. Number three, law enforcement with a subpoena. The licensing board with an administrative subpoena. The patient can request their prescription Schedule 2 through 5 history by law. Units of DPH, Department of Public Health. Has to be existing investigation required. And other states' PDMPs, if authorized and employing confidentiality, security, and access standard, at least as stringent as Massachusetts PDMPs. And this is kind of where the future is coming. State to state sharing data and having on that same level as Massachusetts and other states to kind of identify people who are going state to state with prescription misuse. Also, researchers want to have want to study how much opiates, benzodiazepines are being prescribed, who's being prescribed. They want to kind of get some data on that as well. So some of the national trends with prescription misuse and drug abuse. There's been a massive increase in prescribing of drugs with abuse potential for treatments of pain, anxiety, and other disorders. From 1997 to 2007, there's a 402% increase in milligrams per person of use of opioids. So that's opioids. Fueled by our increases in prescription-related overdoses, drug overdoses have been the number one cause of unintentional death in 2009. Fatal opioid-related Overdoses tripled from 1999 to 2006, now more than heroin and cocaine combined. And emergency room visits for non-medical opioid use increased 111% from 2004 to 2008, and 84% for benzodiazepines. So, of course, the benzodiazepine opioid combination has also driven some of that trend. So, what is prescription drug misuse? Seems pretty straightforward. Non-medical use of a prescribed substance, substance abuse, dependence, addiction, diversion. It does not include the physical dependence because, if you're getting opiates for pain or you're getting benzodiazepines for anxiety, you can become easily physical dependent, but it doesn't mean you're misusing those opioids of benzodiazepines. It's the non-medical abuse. It's the substance abuse. It's the non-medical use with dependence and addiction and diversion that kind of is the hallmarks of the prescription drug misuse. So, what medications are most likely to be abused? You could safely say all of the kind of controlled dangerous substances can be abused, but the most likely ones that currently are opioids, number one, CNS depressants, the benzodiazepines and barbiturates, the stimulants, and others. So really, what's really some of the data trends that are out there, the benzodiazepines, it's really more the more fast-acting benzodiazepines are more likely to be abused than the slower-acting benzodiazepines, along with some of the name-brand opioids as well. So, which ones are more likely to be diverted? Like we went over before, the ones with rapid onset of action, the fast ones, the Xanaxes, the name brands, the ones with intensity of effect. The OxyContin, that's name brand OxyContin, the ones that the Klonopin with the K on it. Along with the cost and availability of the illicit equivalent. So those are more likely to be diverted, misused. So how do we identify inherent medication taking behavior? So there's a kind of a spectrum of patient behaviors that may reflect misuse. One is healthcare use patterns, inconsistent appointment patterns. Two, signs and symptoms of drug misuse. They present intoxicated. Emotional problems, psychiatric issues, always kind of, a red flag. Lying and illicit drug use. Problematic medication behavior, non-adherence. The implication, concerns come from the pattern and or severity and people with kind of differential diagnoses as well. So kind of our big red flags, more likely to be suggestive of addiction. Deterioration at work or socially, illegal activities, selling, forging, buying from non-medical sources of prescription drugs, injection or snorting of medicine, your opiates, your Xanax, your Adderalls, multiple episodes of lost or stolen scripts. My script, went down. My script got lost. My medicines spilled out down the toilet multiple times. Someone stole my scripts multiple times. Resistance to change therapy device despite adverse effects. And Xanax is the only thing that works for me. Only the OxyContin name brand is the only one that works. Refusal to comply with random drug screens. That's a big red flag. Concurrent abuse of alcohol and illicit drugs. Use of multiple physicians and pharmacies. That's a big one that the PDMP will allow you to identify. Multiple prescriptions, multiple pharmacies, big red flag. Yellow flags. Some things can be suggestive of addiction and prescription misuse. Complaints about need for more medication. Drug hoarding, it can be kind of suggestive of addiction. Requesting specific pain medication, or specific benzodiazepines. The Ativan never works for me. Only the Xanax bars are the only ones that will really work, or it's that only OxyContin or Dilaudid, no codeine, just can't have it. Openly acquiring similar medications from other providers, doctor shopping, occasional unsanctioned dose escalation, without talking to the provider or without talking to their doctor, just taking more and more and more over time. Non-adherence to other recommendations for pain therapy and any type of therapy. So how to kind of measure for risk for overdose and misuse, because that's the mortality. People with high doses of opioids, greater than 100, that stands for measurements of morphine equivalent milligrams a day. Prescription drug combinations. We know now about our black box warning with benzodiazepines and opiates. Those together, they have those additive sedating effects. The opiates overlapping with benzodiazepines or muscle actions of both. Two or more respiratory depressant medications are kind of a red flag for overdose. Patients who kind of travel long distances. Residence to prescriber office compared with the nearest prescriber. So if someone's coming all the way from Worcester to Lowell or from Worcester to Danvers, or you get it's kind of a flag. Why? Patient residence to pharmacy, the same thing. If they're traveling all the way from Lowell to Worcester to fill the pharmacy, you got to ask the question why. There might be a legitimate reason for that, but it's kind of a red flag. Multiple prescriptions, always a red flag. Prescriptions from the same class. Two different types of stimulants, two different types of opioids, two different types of benzodiazepines. Multiple prescribers or pharmacies or both. Multiple prescribers, multiple pharmacies, always kind of a red flag that, that may indicate misuse and, should be further queried. So what do we do with this information? So we really have to kind of look at the risk-benefit framework. Judge the treatment, not the patient, because prescription misuse, opioid misuse, stimulant misuse, benzodiazepine misuse, it is a disease. Judge the treatment. So it's inappropriate to judge the patient. Is the patient good or bad? Do they deserve pain meds? Do they deserve anti-anxiety meds? Deserve stimulant? Should the patient be punished or rewarded? It's should I trust him or her? The appropriate thing to do when judging the treatment. Do the benefits of this treatment outweigh the untoward effects and risks of this patient or to society? Is giving this prescription for the opiates harmful to the patient? Will this do harm to patients or society? Will this prescription for Xanax do harm to the patient? Will this prescription for Adderall possibly do harm to this patient? And does that harm outweigh the benefits to the patient? So everyone, you got to weigh the risk and the benefits.